You know, it's a good conference when you've heard from Mark Twain and Reba McEntire and Dan Quayle. We can all retire now. So let me remind you, if you have new questions, to pass them to the end, and the good foundation folks will come and swoop them up, and somebody will bring them. But I'm going to start with what we've got already, and I may direct these to one of you, but all of you should feel free to chime in. And the first couple I'm going to ask for the group as a whole, because this one starts out, that Nichols boy talked about reaching improved outcomes by aligning data and incentives and knowledge of what works. And we all talked about that, obviously. And the example in the question is, in American education, these pieces were put in place with no child left behind, but 14 years later, we've seen no real improvement in student outcomes. Given this, what would lead any of you to believe the same approach would work in an area as complicated as healthcare? Why don't we start with Indu?
So I was thinking a lot about the peanut butter and jelly.
Wasn't that great?
That's fantastic.
Made me hungry too.
Lunch is coming.
But that is that alignment that we're chasing in so many different ways. And whether you say it's an alignment with policy and practice, or an alignment of supply side and demand side, and from my corner of the world, an alignment between the innovation community and the stakeholders that so desperately need it. I think there is a lot of work to be done to think about how do we get those areas where suddenly there's momentum to what we all want to accomplish, but it might require some subtle shifts. And I think why we might be able to do it in healthcare today, I am optimistic. And I think, I tend to be the optimist. My business partner, Matthew Holt, who has been a long observer of the industry, who writes the healthcare blog, calls himself sort of the realist and maybe a bit more of the pessimist. But I've always been the optimist. And I think why right now, it's because if you take the challenges that Mark laid out and you say, okay, now let's really elaborate on why this is ridiculous by putting tools and technologies in the hands of those providers and those patients to document and capture why we're missing each other so badly. I think if you bring these things together, we will get that alignment. So to me, to answer your question, why will we succeed in healthcare where we failed in other areas? I think it's because of this policy meets technology, meets certain natural drivers today that are out there, and we just have to get the peanut butter and jelly to come together.
Very good. Mark?
So I have to add another quote, because it's not only about the optimism, but it's also about the timing. So Upton Sinclair, in his great book called The Jungle, about the Chicago stockyards in the turn of the 20th century, wrote one of my favorite lines of all time. It's difficult to get a man to understand something if his salary depends on him not understanding it. When I met James on the phone, why I knew the timing was right at the Colorado Health Symposium was because the providers now care a lot more about what their patients are doing, because they will be, for the first time, accountable. So when I would go to physician groups and say, you are being benchmarked on X, drug, test, follow-up, visit, and told physician groups that their patients are enrolling in health plans that don't make it easy, which you'd think would be the case, but actually make it hard for them to do those things, they started backing what we're doing. They started backing the idea of mobile health technology. They started understanding that it takes not just the peanut butter and the jelly, but also the bread and the bananas or whatever else, the ultimate levers that are going to need to make this happen. But it wasn't until the bravery of the payers to say no mas, fee for service, which is why I've gone from curmudgeon to cautiously optimistic.
Very good.
Yeah.
James?
I think I'm optimistic as well, but I also believe that in the design stage, we need to pay more attention to unintended consequences. So I think those who kind of draft a lot of this legislation, we need to play a role in that. Many of you might not know that CMS, as they promulgate these regulations, they often have a comment period where you can shape some of these regulations. Often it's just the lobbyists, no offense, who are chiming in to shape these types of regulations. So I also believe it's going to take individuals who recognize they have more agency in their collective organizations. It's not always the CEO that can move the dial. It's those on the front line who can help to shape an organization's culture and values so that it moves in the right directions. Unlike what's happening in Washington, we need to move and reach across the aisle in our respective organizations. I think we all know there's things that happens in our organizations that might not move the dial in the right direction, but we're all wrapped up in these complicated structures, and we have a passivity that allows it to occur. So I just think that we need folks who are going to expose the dark underbelly of our different organizations. If we have a low penetration rate in behavioral health, for instance, across the nation, where we're getting paid on, to serve 100% of the population, but studies show only serving 15% of that population, that's something that we need to call out. And it'll never be understood on the terms in a nuanced fashion unless it comes from the inside of that industry. So I just think that we all collectively need to reach across our organizations, maybe collectively put ourselves at risk and move in the right direction. And I think we can hit those unintended consequences.
Very good. So we've all talked about the degree of change, and we're all excited about it because we're either cautiously or wildly optimistic by nature. But other people are more concerned about kind of the downside of the stress, or maybe just confused about the stress. So one question I think James talked triggered, but clearly all of you could answer, is why is there so much turnover of healthcare CEOs? What the hell is going on?
Well, this again is not going to be popular, but I'm not running for office. Some of the turnover is good. I mean, we've had a lot of people who've been in position for a long time and often are able to bring in boards of directors that support their, aspirations. So I think it's a tremendous opportunity. I mean, let's face it, the healthcare leadership looks a certain way. The hospital industry is about 75% women. That leadership is not reflected by 75% women. It's not as diverse as it needs to be. We all know that the outcomes are better if you have people who look like you treating those patients, who speak your language. So I think it's a tremendous opportunity for some of that change to inspire good. When you ask the question of why it's happening, I just think there's a lot of pressures, right? It's very different to say, hey, fee for service, let's churn procedures, let's work closely with doctors, let's bring that volume in, to saying, hey, now you got to be preventive. That's a very different thing. In Massachusetts, we were calling it a structured schizophrenia. On one side, the fee-for-service. On the other side, this preventive health. And a lot of folks who are trained in this older model of volume, regrettably language like heads and beds, aren't ready for this preventive work at the same time of heads and beds. I can tell you, we have a lot of Masters of Health Administration folks in healthcare. We need more Masters of Public Health folks in healthcare who understand kind of the environmental, social, and behavioral determinants of health in a nuanced fashion. Again, it's a little bit embarrassing when folks on the inside of the health industry say, hey, this new population health stuff is so exciting. I was like, one, it's not new. Please don't say that publicly, but these are the comments you're hearing. So a lot of work to be done.
So speaking of work to be done, Mark, I know you're associated with one of the nation's best medical schools. What are the AMA and med schools doing to provide medical professionals with the business and financial acumen to move to this new value-based insurance reimbursement system?
So the answer is not enough, not enough. I think, as all of us know, training new clinicians is the long-term answer when we're going to be gone. I mean, I think there's so many clinicians out there who can really understand being re-engineered now. And I do believe that Americans, whether they be in the clinical medicine or not, respond to incentives. I think that we're starting to see people who used to be the most profligate on dealing with the volume side. Mm-hmm. These same providers, when incented on the value side, they also perform the best. The other point I think it's worth mentioning is how do we make this actually happen? Since someone mentioned lobbyists, I think James just did. I was asked during a Medicare Payment Advisory Committee hearing about this idea about buying more of the good stuff and less of the bad stuff is like American apple pie. But he said, Rob Reischauer, said to me, this is a town of winners and losers. Who are the people who lose in the movement to clinical nuance? And my response now, 5 years ago, which I love saying, is the people who lose in clinical nuance are the people making money, not making Americans any healthier. And the beauty of that is no one's willing to admit that's them, right? So why I've been able to get Republicans and Democrats and management and labor and other organizations is, as Trunu continually reminds me, you have to tell every audience how unbelievably inefficient the status quo is. That no one would ever invent this system that we're in, and that we need these marginal movements that are aligned to pull us out of the quagmire.
Very good. So this one's for Indu. How do you achieve integration of meaningful health data and all these marvelous platforms in an environment of proprietary apps and data and so forth with the public perception of privacy at risk?
Right. So I'm going to go out on a limb here and say I don't think it's privacy concerns that's holding back the adoption of these technologies. I think that was in the early days a big concern that patients are never going to want to share their data. Patients are concerned about their data, being attacked by cyber invaders, what have you. I think our common sense listening and our common sense conversations with people over the years from all communities, from the patient community, the physician community, the tech community, is that at the end of the day, the frustration is greater on that access and that continuity side than it is that my data is insecure. And that does not mean that we should underestimate the threat, to digital data. It certainly exists. There are certainly steps institutions need to take, but for me personally, I found HIPAA to be more of a barrier in getting access to something I need in a timely way than in something that's actually protecting me. So I would ask, can we reframe that question about is the fear of privacy and the threat to privacy greater than our need for access right now? And there's such an urgent need for access, such an urgent need for sharing. Does it have to be a trade-off? Can we do both? Can we do both reasonably well, have reasonable things in place to protect privacy, but enable a lot more? And I also think sometimes that gets cited by entities that can point to that and say, well, that's the reason I'm not integrating, when in fact it might be other factors and we have to dig at the surfaces of that. So right now, the good news is we have measures in place for modular components to the EMR to exist, in a meaningful and safe way with the EMR. That's there. The protocols are there. What is the issue? Meaningful use is there. Policy guidelines are mandating it. What is the issue? Why do I still, when I call, this is my question, rhetorical, meaningful use says I have a right to my records. I should understand the visit. We've got all the, high-tech act dollars saying, doctors should invest this and the other thing. Just the other day, I would love my records to be transferred from my doctor to another provider. You'll have to come in, fill out a fax form. Then it's going to be 3 weeks. It'll cost you $70. This was like 3 weeks ago in LA. So what is that about privacy? What is that about? And I think we've got to answer what that is about first. And so
Very good.
Yeah.
Okay. So James, could you share more? People were clearly intrigued with how public health departments can share in the risks and savings associated with these new payment models.
Yeah, it's a good question. So what I was laying out is a question of the move from volume to value. On the volume side, we know some of the risks of churning. On the value side, the real risk is skimping on care, right? Because you can reduce that budget by not providing needed procedures. Unlike the 90s, this time around, there's some checks against that. We have some quality checks. We have some patient satisfaction checks. So some of those potential concerns should be resolved. What I'm highlighting is because we're in this new budget-based care, in the past we just looked at medical procedures and said, what are we going to throw at folks? There's an opportunity to throw other types of resources at individuals. For example, I highlighted that we were giving healthy meals to individuals. That's not something that hospitals would normally do. But in this new arena, if that is going to move the dial and keep somebody under a certain budget, let's do it. If you're going to be able to go into a certain house and do lead-based paint abatement to reduce the asthma of children and prevent the recycling out in and out of the ER, let's do that. One of the things we're starting here now and that I put in place in other hospitals is medical legal partnerships. Some argue the best intervention sometimes is a legal intervention to reduce the cost of care. Oftentimes, again, patients are cycling out of the ER, call a landlord with that person, give that person a lawyer to call the landlord. The landlord says, oh, I didn't know it was an issue. No, you didn't know this poor person had a lawyer, now fix it. And all of a sudden, we are able to reduce the cost of care. So when I think of what the role of public health can be is to really understand the tenets of this new model, understand this new finance model really well. Understand how the quality metrics, what the quality metrics are in these different contracts, and then engage health systems in that manner, in those terms. You know, it's one thing to say, hey, we can improve the community's health if we do X. It's a very another thing to say we can improve the community's health and enhance your strategic imperatives by doing X and Y. And I think that's the piece that's often forgotten. Oftentimes people come in with great ideas of what can be done, but they don't understand the inner workings of the health system. They don't understand how we're incentivized, and those meetings never occur again. So again, a tremendous opportunity for the public health folks who have those relationships, who have a denser understanding of what it means to improve that population's health. You just haven't had the resources in the past. So the question is how you marry the resources of health systems with the great public health work that's been done for centuries.
Great. So Mark, you documented that the increase in coverage has led to many benefits. What do you think is the percentage of these patients who have a good understanding of their benefits and how to use them to their full potential, and how do we increase that? I assume all of you will comment.
Yeah, that's a great question. I think there's a group of us getting together to discuss this issue of health literacy, and I know Indu mentioned that a little bit, and then again, that's above my pay grade. I think that this is a very, very complicated situation, and I think James just pointed out this part that as a public health professor and a medical school professor, it's been very interesting that those schools which should be siblings are at best step siblings and usually not siblings at all. I want to just tie a couple things together as well. I love sidewalks and pest control and low-cost meals. Going back to my biggest concern is I talk about public health, I talk about population health, and when I leave an organization, the question is I'm getting into the cab is, and how much money are you going to save me, right? So I'm not, I become an I can't beat 'em, join 'em guy. I understand that we have to talk about return on investment, and because of the importance of return on investment for both public and private payers, my last quote of the session, Len, is from Willie Sutton, the bank robber. When asked, why do you rob banks? He said, that's where the money is. And I think everyone in this audience knows that 5% of Americans generate 50% of the spend. As a public health person, what we kind of should pride ourselves in, but don't realize that the healthiest 50% of Americans generate 3% of the spend. So even if I got rid of all of the spend for these two healthy people besides me, you wouldn't even see it, the CFOs in the room, which is why we have decided to, against some population health initiatives, to focus on those who are most in need. From a medical evidence perspective, the good news is for those clinical conditions that both of my panelists could say that generate all this money, we have evidence-based services, for which now under the new models, clinicians are being paid more to do, for which the customer is not being said to do the same thing, which is why, if we don't have peanut butter and jelly, we're not really going anywhere. And it's so problematic for me to see individual organizations who are working so efficiently, proficiently, but the silo still exists. I mean, you and I have been talking about the silos in healthcare for 2 decades, and it's hopefully meetings like this where the stakeholders come together and say, you know what? We really should be buying more of these things and less of others. And the fact that the point I wanted to make on James, the tie that we tried to do in the ACA to bring public health, prevention, and chronic disease together was Section 2713, which mandated now over 70 screening and preventive services to be at zero cost to Americans regardless what plan they're in. They don't know it, they don't go, and now more importantly, which is I guess a sad note that I'll end on, I have been getting emails for now since 2010 when 2713 was put in effect. Dr. Fendrick, thank you for the free mammogram. I have to foreclose on my house to pay for my mastectomy. Dr. Fendrick, thank you for the free colonoscopy. I now cannot afford the drug that my doctor tells me I have to have, which throws a whole dynamic in the family and the turmoil and the savings and whatever else. So, I implore this audience, if you don't start looking at the services that you're buying in a way, not by what the price tag is, but how much healthier it makes individuals or populations, you are not going to succeed in the triple aim. Because you're going to see more and more of these high-cost things. And some high-cost things are worth buying, like those boots. And some, low-cost things are not worth buying, like this shirt. So the idea is you need to decide what are the things you should be buying based on a new metric. Not profitability, because James says that's gone, but instead this new health metric that Indu and others will help us do a better job making that kind of literal and to various stakeholders, some that are less sophisticated.
Very good. Indu, how can technology help?
Yeah, so I was at a hackathon, and I don't know how many folks in the room have been at one of these, and you can call it a codathon or a hackathon, but it's sort of an 8-hour to 24 to 48-hour, depending on how you structure it, session where people from different disciplines get together and actually build solutions in real time. At the end of a day, you don't necessarily get enterprise deployable IT systems, but you'll get a good prototype. And one team took the benefits that were free to people under recent legislation and new types of plans, and said it's not good enough. Free is not cheap enough, right? That expression. So free is not cheap enough. It's not enough to say they're free. Why aren't these people rushing out in droves to use them? They built an app that would help you find those services in your neighborhood, that would make it kind of culturally and language-based relevant to me. And it was a young team doing this on a weekend, and I thought, there's something to that. There's something to the fact that we're all sitting here going, what's the problem? And coming from the private sector, coming from the startup community where you have to sell your product to make money and exist another day, you don't sit around and say, well, no one's using my product. It must be because they're not motivated. No one's, it's because I didn't build a good product or I didn't communicate its benefits well. Nobody sits around blaming the customer. You're not going to be in that startup the next morning. You won't survive in Silicon Valley if that's your approach, right? So the burden is on those product developers, and we have an opportunity to work together because that development can't just come from one discipline. It can't just be engineers in a room. It can't just be physicians. It can't just be executives. It's got to take that team approach. So that's one thought. The second is, I think regarding services and how, I just want to tell a little story about my father-in-law, speaking of in-laws. So, he is on Medicare and recently kind of complained of sort of loss of sensation in his fingertips and toes, and you would know that as peripheral neuropathy. And after a long series of workup, it was determined to be idiopathic. Nobody knew why. One of the things that it could be, even though it's not really showing up on the blood work, is, it could be related to being pre-diabetic and the blood sugar, et cetera. That visit ended with, you ought to see a nutritionist. That's it. And, no surprise, we come home to dinner and he says, as he's reaching for the giant chocolate chip cookie that I'm holding, so is that glucose the same as gluten? And this is a smart UCLA lawyer. I mean, this is a smart. We're making assumptions about not people's desire to take care of themselves, but just they need a little bit more connection there. And so I was thinking, what would have been better than you ought to see a nutritionist. I don't think he's going to make that appointment unless I make it for him. He's always on Ask Siri. He's always on YouTube. He's always, he's on his phone a lot, actually. And new data showed that the elderly are using smartphones, and had that referral been more to something like, here's this really interesting, cool thing. Look, I'll pull it up for you on your phone. Just go home and look up what foods have sugar. He would have been, now, if I wasn't in his life, God forbid, that man could be a few years away from having a fall, from burning his hands in a hot water tub at home, because those are the things that bring you into the ER, and then that cause problems. So here's a live case. Could he have been referred better to a more intelligently designed product and solution that could have preempted those downstream outcomes?
So James, how can a hospital and ethical executive help to this conversation?
Yeah, well, I think just want to unpack a couple of themes. So one, given that we are in this new model of value-based care, hospitals are now for the first time hiring statisticians and others, and we're stratifying diagnoses and costs and challenges around the most complicated patients. So, with financial incentives to address that, I think you'll see quick action to address it. But I just want to highlight a couple of ethical challenges along the way. So back to that example I gave, I showed a very healthy person and I showed a very unhealthy person. The real question is, as we move towards these assigned lives, is there going to be cherry picking by systems of the healthy patients and lemon dropping, if you will, of the unhealthy patients? It's very complicated, but there's ways in which the game can be shaped a certain way, if you will. And that's something that we all need to monitor. And when you think about the new transparency movement, one thing that's often left out of the transparency dialogue is the transparency in these contracts. Because if you're in a fee-for-service contract, there's a certain communication that might happen. And if you're on a value-based contract, keep you under a certain budget, there's a different conversation that might happen. And the way to think about this is the lens of grandma. Now, does grandma need that hip surgery? Think about it. Grandmas, cookies, apple pies, we love our grandmas. Whether or not you need that surgery oftentimes can be shaped by the dialogue of that doctor. My mom would listen to her doctor much more before she listens to me. Doctors have this heightened respect in society, and the language they use is important. So if you're saying, oh, hey, Mrs. Jones, I'm not sure you need that procedure. You're in the budget-based world now because the evidence is mixed whether or not the outcomes will be effective. You're going to have one choice by that patient. In the fee-for-service side, if you say, hey, grandma, I think you need that surgery because X, Y, and Z, you're going to have another outcome shape. So I think if you have a transparency tied to these contracts, you'll equip the consumer to be prepared for the way things are communicated and to defend themselves in this changing world. And I want to close by just saying that this complicated structure of health literacy is so important. Some studies show that upwards of 40% of the new Medicaid enrollees who are coming into our system don't have basic literacy skills. So what good is it to say, here's your follow-up appointment? They're not going to tell you they're illiterate. What are we doing on the front lines of systems to collect data? I can tell you we're not where we need to be. That's an area that we need to scrutinize more. Because we're talking about looking at patients on their terms, based on their education, based on their race, based on their gender. It all starts when they come in the ER and patient registration. But it's very complicated, as you can imagine. You're coming to the ER in emergency and you're saying, what race are you? Can't you tell I'm black? What's your education level? What the hell's that got to do with my care? These are complicated conversations, but if you script the frontline staff, you'll get the data, actionable data, that will help health systems. So a lot of work to be done in a lot of different arenas.
Very good. So this is, I think, a pretty subtle question. I'm going to start with Mark. What are the best practices for getting people to take more responsibility for personal health? And in particular, they're focused on the Medicaid and lower income populations. Would personal responsibility agreements help achieve this for these kind of folks? What do we know about really reaching into situations where you can't really use it?
I think I would better answer that question after a cardioprotective alcoholic beverage. I'll try to take this on, but punt a little bit, because I was brought here to answer your question 4 about tools. I think that maybe my colleagues will be able to handle some of these greater, more philosophical questions. So I want to make sure this is clear. I think this is the third time I said it. I think both the clinicians and patients have had it too easy in the system until the recent years due to the lack of accountability around health. I think that, as James articulated so well, whether the clinicians like it or not, this is starting to happen. And I believe that through Secretary Burwell or places like Catalyst for Payment Reform or HCI3, that movement to quality-based reimbursements will be real. And as James pointed out, most of them will still be fee-for-service. So it's not that we're going to get to the old-fashioned managed care 1980s backlash that you and I kind of grew up with. The idea that you have now coverage doesn't mean you should have unfettered access at no payment to everything. And that is, as hard as the literacy question is, I believe the idea of clinical nuance is going to be very hard to explain, but we should approach it from the low-lying fruit of the things that we all know that are good for us, grandma or not, and choosing wisely has helped us with the things that are bad for us or not. So here's the punt. I believe that the consumers should be engaged, and I think that they should be accountable. That doesn't mean that they always have to pay more for everything, right? And I've come up with some of these ideas from other industries where you might be able to say the patient's engaged but not disincented to do the right thing. So a lot of you in the room are worried, if not increasingly worried, about these high-cost, expensive drugs and procedures for which they're high value. And I would argue myself that there should not be a large amount of financial exposure for the patient to them. That's a semicolon, not a period, because I don't think that means that the patient should get off the hook. And I've thrown this idea around the country in some forms of accountability that may not mean to money spent, like a down payment. So I've been very active in these specialty drugs, $100,000 for hepatitis C, whatever else, and I like to tell the joke, I saw a patient drop a Sovaldi tablet, the hep C treatment, it's $1,000 a pill, on the Denver airport floor yesterday, and he was about to throw it away because he didn't know it was $1,000. I'm like, 5-second rule, take that pill, it's $1,000. And like, most people don't know that pill's $1,000. Most people don't know that the inpatient technology that they get are tens of thousands and hundreds of thousands of dollars. What about the idea of having that conversation, but instead of asking them to pay for it, which is what's going on now, have them put down a down payment? So here is that I understand that this is a $100,000 drug. I know that my gastroenterologist, hepatologist, doctor says I should take this $100,000 drug, but because now that we're seeing 1 in 10 people don't finish the course, what about asking them to put a needs-based down payment down, that if they show that they take all the medicines or do what they were supposed to do for their diabetes or their heart disease or their mental health, that they actually get the money back? And we've had no one implement this yet, but there are a lot of people kind of considering alternative models for engagement that do not automatically mean higher cost.
Very good. James, any thoughts on that?
Yeah, I got to say I'm a little troubled by the question. The underlying premise of that question says that personal responsibility. Thank you.
Good. That was why I punted it, but thank you for the pause. Yeah.
Well, because I guess, one, personal responsibility is something that we can all encounter, right? So in a state that doesn't require folks to wear helmets, what's the personal responsibility in that when someone, has an accident and their cost of care exceeds the payment in their individual insurance, and we all bear that payment ultimately? There are some structural issues at play. So if someone's in a certain zip code and it's not easy for them to go out at night and run and exercise and they're obese as a result of it, is it their fault or their structural issues? If they're in a food desert, is it their fault or their structural issues? I just wonder and worry that we are victimizing the victim a little bit more. I mean, let's face it, Medicaid, I'm glad that we have a Medicaid expansion, but it's an underfunded, underpaid service. So if somebody's on Medicaid and they can't get the treatment they need, be it behavioral health, pain treatment, or others procedures, and then they're cycling in and out of the system, and then we blame them and say, you're not being personally responsible, you're misusing the system, I'm deeply troubled by that. I don't want to take the individual accountability from that person, but I want to look at the structural issues as well. And together we can fix those structural issues. And once we address those structural issues, then let's talk about the personal accountability of that individual who no longer has these structures in place that impact their health.
Bravo, bravo.
So, speaking of structural issues, for Indu, what role does or can government and public policy play in fostering Health 2.0 and your progression across that?
I think it already has done a tremendous amount over the last few years, and I think I mentioned a few things, but the health data liberation movement, which basically challenged all institutions to make data more available and open, starting with the CMS charge master release of data from many, many hospitals a few years ago, to individuals sharing their data. So I think that has been a huge kind of rallying cry for the community, and that's a good thing. But when I think about the data that you need in your world for value-based insurance design, it's like not enough. We still need to get really a lot more granular with our data. We may not be collecting the data at the right level of specificity in the right circumstances. may not be to get to that clinical nuance piece you talked about, which I thought was really interesting. There's a lot more to be done besides just making data available. We might need to change what we're collecting and look at different sources of this data. So to me, the data liberation piece has been huge from a policy standpoint. The other one, basically under the Affordable Care Act, certain things, you have many detractors in the community I'm from who say that many things under this well-intentioned policy stuff has just basically encrusted old practices or created different models of kind of silos and things like that. I don't think so. I think ultimately this idea that we have to look at the determinants of health more broadly, that's going to create opportunity for technology to be that connection into the larger system. It's going to be both that inflow and that outflow piece, and I think that's an opportunity right then and there. And in terms of getting paid, which a lot of people in the tech community worry about, they need you. So think about this now from a market standpoint. Not only is all of this the right thing to do, but these are businesses. Hospitals are businesses, even if you're nonprofit, even if you're faith-based. These are businesses, and so is the tech community. These are businesses. And I think what we have to think about is they need distribution to reach customers. We have access to members. We have services that aren't getting utilized properly. So we have a business to run. And I think that, to me, is one of the ways in which policy can really help align that value equation for both these creators of solutions and the people that need them. There's a lot that's still in the way of that, but ultimately that's what's going to give the forward momentum, where it's not like this is a checkbox. Policy often gives us a bunch of checkboxes. I'm doing that community-based survey I'm supposed to, done. And there it sits in a site no one is going to use. Open that up to entrepreneurs. Make that in every neighborhood. Let everybody see it. And one last thing, I think I wanted to jump in on the point you made earlier about individual responsibility, because policy can only do so much. I believe in the structural issues, but I also believe while we work hard at those over a lifetime, there are some short, easy fixes. And the one thing I will say is we make a ton of assumptions about, we're so focused on literacy and we think it's so impossible. We make a lot of assumptions about what people can understand about their health data. And I'm having really fascinating conversations right now with a lovely woman who helps me clean my house. And we talk about her hemoglobin A1C, not because I'm bringing it up, because she's tracking it aggressively. And she knows more than my UCLA-educated father-in-law, frankly. She really does. Okay, and that's an assumption we need to challenge. And it's because someone had the decency to talk to her about the data, to make it her own, to make it her journey. And I think we've got to stop with the assumptions. And one last thing on that, my little soapbox here is doing it from the walls of the hospital. It's models like the Chicago barbershops that my physician friend who's working for Rahm Emanuel is trying to do, getting those services out into the community, contextualizing them, and then it's going to take off. So I think I don't think we have to wait till there's entire structural reform for decades. I think there's easy fixes, but it has to do with challenging our assumptions, using common sense technology that people interact with every single day, and just like getting on with it.
Very good.
Yeah.
Mark, you want to add something? So a question was asked about how, Indu, you talked about democratizing healthcare, and James, you talked about conglomerization of healthcare. And the question is, how are these forces both reinforcing and disrupting each other?
Oh, I guess I'll take a shot at it first. Yeah, I think that's a great question. I guess what I was trying to highlight is the conglomerate is just to people to be aware, right? I mean, there once was a day where you had your independent community bank, right? Some savings bank, and that was your bank in your community. And then we are today where there's these mega systems and mega banks that transpire across states. I just wanted to highlight that the same thing's happening in healthcare, much of it driven by the way we paid for it. I mean, let's face it, in the 60s, before we opened the Treasury to pay for some of this under Medicaid, Medicare Expansion Act, a lot of the support for that hospital was driven by that community, by charitable donations, by doctors' wives and others. That was their community hospital. And I just wanted to highlight that I think that is changing as we corporatize healthcare. And if health is a social good, we cannot do that without understanding some of the ramifications of the full corporate assault on health, if you will. So in terms of the democratizing of it, yeah, at the same time, people want more access to their data. People want to be able to be in control of their health. And that's something that healthcare, I got to say, is struggling with. I mean, I hear some doctors, not many, thankfully, are saying, well, my patient comes to me and he's read all this stuff on the internet and he wants me to answer all these questions. And I'm thinking, well, what the hell is wrong with that? And my patient thinks I'm serving him and not treating me as I am this. And I can tell you, as a person with a law degree, I mean, lawyers dealt with that a long time ago. Nobody trusts lawyers. You get a second and third opinion. So the fact that this heightened sense of respect of the medical profession, mostly deserved, is in place doesn't mean that we are not open to scrutiny, are not open to questioning by our consumers, and it doesn't mean that we should not think about the importance of ensuring that there's an equitable structure that allows the people who look like those patients to be served by people that look like them. I want to go back to that again and again, because I think that it's one thing to have sympathy. I feel sorry for you. I understand your pain. It's another thing to have empathy, where you can put yourself in that person's position and you can feel their pain in a way that makes you move the dial. And I think we need more of that. And that's often easier when you are having alliances with someone based on culture, race, gender, or experience.
Very good. So as usual, we have way more good questions than I have time to ask our panel. So I'm going to close with what I call a lightning round. You get 20 seconds each. And the question is, what's the one thing you would like to see in the state of Colorado that is not here now to advance your objectives? I'll start with James, because you've thought more about it.
More understanding and alignment on the payment model. I want us all to take collective risk on improving the health of the communities we serve. And I mean downside risks. Because it's one thing to say, oh, we lost out on some opportunity to make revenue. It's another thing that says, holy cow, we're losing money. We're going to have to close if we don't figure out how to fix this. That moves the dial a little bit differently. So let's take collective risk on some of these patients we're serving.
I'm going to flip the answer and say that there's something that you have here that's working really well. I just learned about the Digital Health Accelerator, 150 companies based in Colorado trying to innovate, supported by the foundation in part. I would say think about how those companies can not only prove value for health systems, but how they can be valuable in the community. And by that I mean non-traditional partner organizations, schools, senior housing, all neighborhood level. So can we take the lessons you're learning and the processes you're building to study these digital health technologies? Kudos to you, but let's extend it to all the environments besides just the health system setting.
Very good, very good. Okay, Mark.
As the person keeping them from peanut butter and jelly, I will say it is absolutely critical to embrace the idea of clinical nuance. There is more than enough money in the system. We are just spending it in a very inefficient and irrational way. And as we move with these really kind of lightning-paced initiatives forward around these things, if we don't have alignment, we will get nowhere close to the goals of the triple aim as fast and as far. And please Google VBID. We passed Vehicular Borne Incendiary Device in 2003. Chime in on what we're doing. Please contribute. We've worked closely with a lot of the organizations in the room. We want to help you in this state move forward to that ever elusive triple aim that Len started us off with.
Very good. And so speaking of the ever elusive triple aim, lunch is on the patio. We will be back very sharply at 12:15. Join me in thanking this amazing panel.